from us?
Hi.
Okay.
Hi, Dr. Gu.
Okay. Thank you. Actually, we are very familiar with Professor Rim. He once visited and spent 1 week in our department to communicate with us, and he gave us many good options and advice for our ablation technique. So today's his topic is tips and tricks for.
Okay, good afternoon, everyone. First of all, thank you for inviting to this wonderful conference again. Actually, I am very missing all of you, so I want to attend the next meeting in person. Today, I'd like to talk about the donuts. As we know well, circumferential and sufficient ablative margin, 5 to 10 millimeter, is essential for the best outcome after ablation. Why ablative margin is important? Because of microsatellite nodules or microvascular invasion around the index tumor. So as the tumor is getting bigger, micrometastasis or microvascular invasion frequently occur, and unablated lesion lead to local recurrence after radiofrequency ablation. This is our old study in 2010. As you see, insufficient ablative margin was the sole significant factor associated with local tumor progression. So insufficient ablative margin can be a factor on local tumor progression after reablation. And also a recent study from China demonstrated minimal ablative margin of 0 millimeter was the main factor associated with local tumor progression. So again, insufficient ablative margin is a factor on local tumor progression. But local tumor progression really does matter for survival. From Japanese study, as you can see, the survival and disease-free survival was better in the group of sufficient ablative margin compared to insufficient ablative margin. Again, sufficient ablative margin can provide better survival in terms of overall as well as disease-free survival. Another recent our study updated 10-year outcome of RFA as the first-line treatment therapy for single HCC smaller than 3 centimeter. In our study also demonstrated local tumor progression was the important prognostic factor for overall survival after radiofrequency ablation. Again, sufficient ablative margin can provide better survival. That's why we should achieve sufficient ablative margin as much as we can. I think there are 3 keys for successful ablation. First, precise planning. Second, accurate procedure. Third, lesson from each case. Planning, accurate procedure, learning from each case. Today, I'd like to propose 7 technical tips and tricks for ablative margin according to these 3 important key: planning, accurate procedure, and learning. First, understand the index tumor in details. Second, define the target thickness of ablative margin. Third, decide energy source, applicator details, location of applicator placement, ablation power and time, and so on. Regarding the accurate procedure, we should place the applicator accurately first and define the target boundary of ablation zone, including ablative margin, before starting ablation. Next, close monitoring and controlling until the optimal ablative margin is achieved. Finally, assess the ablation zone in detail on post-ablation imaging study. I think all of you in that room already knows very well because this is really basic. But in my opinion, the basic is more important than just novel things. So shall we start with one by one? Regarding planning, precise planning, first, we should understand the index tumor in detail as much as we can, not just the tumor size and location. We have to check many things. Second, define the target thickness of ablative margin before starting ablation, depending on the tumor characteristics. Third, decide energy source, RF, microwave, cryo, and applicator details. Understand the index tumor in details. As we all know, not all the tumors are spherical, like ping pong ball. So we should consider three-dimensionally. It is very critical part to achieve optimal ablative margin. For example, if you have any tumor, we should measure precisely in different planes, axial, coronal, sagittal, including the maximum and minimum diameter. This is very important. We just guess, we just do procedure with just maximum tumor diameter, but we should be measured carefully in 3 dimensions. And also, the microsatellite distribution is increasing as tumor size increase. So if the tumor size is larger than 2.5 centimeter, we should achieve at least 1 centimeter, 10 millimeter circumferential ablative margin to cover this kind of microsatellite nodule. The tumor size is less than 1 centimeter. I think 2 to 3 meter ablative margin is quite enough based on this pathology study. Traditionally, ablative margin is recommended 5 to 10 millimeter, just borrowing the surgical resection concept. But at the moment, there is no enough evidence supporting this data. So I propose if the probability of microsatellite nodule increasing, we should increase the ablative margin, increasing ablation thickness for larger tumor, irregular margin, and microvascular invasion finding on CT or MR finding over high tumor markers. So more specific ablative margin thickness according to the characteristic of tumor is necessary at planning phase. So we should be more flexible for ablative margin depending on the tumor characteristics. In that sense, multiple applicator may have more benefit compared to single applicator. The next technical tip is decide energy source, applicator details, and the location of applicator placement, and ablation power and time. As we all know, planning is almost half of successful ablation. For example, we should decide which energy would be better for the particular tumor, and application number, gauge, active length, and perfusion type or not, the location of antenna, tumor puncture or marginal puncture no-touch technique, and the position supine to LAO, diffusion or CUS or CT guidance as well, and monopolar, bipolar, and whether we have to use artificial sinus diffusion. So precise planning on all the details in the ablation procedure should be defined in advance before starting ablation. Again, planning is most important. Let's move on the accurate procedure. First, we should place the applicator accurately. Second, define the target boundary, including ablative margin, and close monitoring and controlling when the optimal ablative margin is achieved. Place applicator accurately, like this. We try to make 10 as much as you can. The other half of securing successful ablative margin depends on how much electrode are inserted in the planned location, exact location, accurately, and provide sufficient ablation. Like this. Either you use a single electrode or 2 or 3 electrodes, we should be punctual as Swiss watch. Next tip is to define the target boundary, including ablative margin. This is very important to get the optimal ablative margin, not insufficient, not excessive. So as we know well, if you use ultrasound guidance, the lesion conspicuity at the ablation field is getting worse just after starting ablation. That's why it is very important to figure it out, the index tumor and the target ablative volume is very important before starting ablation. Sony window is almost always getting worse after starting the ablation. Before this kind of cloud, we should identify the tumor and ablative margin. This is very important. So targeted boundary of ablation zone surrounding the index tumor should be defined before starting ablation. Another tip is that we should remember any kind of landmark point, the vascular branching or cyst or calcification or previous ablation zone as a polaris like this. So that before starting the ablation, we should check this kind of any landmark. This is very important. Okay, next tip is close monitoring and controlling for optimal ablative margin during the ablation like this. The final key to proper ablative margin depends on how closely the ablation zone site is monitored, on whether there is any insufficient ablative margin at specific point, or whether the ablation parameters needs to be adjusted, increased or decreased, or additional overlapping ablation is necessary or not. So this monitoring and controlling very closely is very important. The final tip is regarding ablative margin is learning from each case. That means assess the ablation zone on post-ablation imaging study in details. This is a pre-ablation MR and post-ablation CT, but most of ablation is just check, oh, this ablation is enough and no complication. But there are many things to consider in detail even after successful ablation. And some researchers propose this kind of registration software provide a better ablative margin assessment than just visual inspection. I agree, but I'm not sure the most researchers continue to use this kind of software in their practice. So I would say software may be useful, but I think not essential. After the ablation and after getting the post-ablation CT, I kindly recommend to you to ask 7 questions to yourself. First, was the electrode inserted in the correct position along the path I originally intended? Second, was the ablation zone similar to what I initially expected? Third, was the energy, type, and number of electrode, ablation power, and time was the appropriate? How much did the effect of artificial cyclical refusion secure ablative margin? Was it optimal ablation or insufficient or excessive ablation? Why? If there was insufficient ablative margin, was it impossible to identify it during the procedure? Finally, if you made additional ablation, was the ablation, overlapping location site accurate? Was the ablation time accurate? This is my example. The 1.5 centimeter in the center of left lateral segment. On planar ultrasound, the lesion is relatively conspicuous, is not bad. So I inserted two radiofrequency ablation electrode like this. After checking the tumor size, tumor boundary, and the targeted ablation boundary, ablative margin including, I ablated for 8 minutes. So at that time, I was quite sure I would make the circumferential ablative margin a nice ablation, including at least a 7 millimeter ablative margin. But this was the result. As you can see, the ablation volume is not bad, very similar to breast circle, but ablation location formed a little bit anteriorly. That means the posterior ablative margin is not ideal. So if you ask the 7 questions, you can find what was my mistake when I insert this electrode. The tumor was here. Definitely the ablative margin is not enough, just 1 to 2 millimeter. So I recommend we have to learn from every case, even the simple case. So I initially expected I inserted this area 3 and 9 o'clock, but in reality, I might insert a little bit anteriorly like this. So that's why ablation zone like this. So learn from each case. This is the most important, very basic, but most important. So if you do well done, so repeat again, do repeat what you have done nicely. Do not repeatedly when you have done wrongly. And if you have a lesson of each case, please share the lesson with your colleagues. Okay, today I'd like to talk about donuts for ablative margin. So I hope you can remember from 1 to 7 basic technical tips. I believe all of you already know that, but sometimes we forget. So I think the novel is important. We should be developed, but more important things for best result of ablation is basic. Thank you for your attention.
Thank you to Professor Rim for giving us such an impressive and academic lecture. So as we all know, complete ablation is very essential and very important for long-term survival. And a complete ablative margin plays a very important role in complete ablation. So Professor Rim concluded this 3 keys and 7 tips and tricks for us. So like plan, accurate, then in his 7 tips and tricks, including understanding the index tumor, define the target thickness, divide decide energy applicated health, accurate function, and immediately imagine evaluation post-ablation also are very important for achieving good ablation margin. So sometimes we need to define ablative margin depending on tumor characteristics like MCRC, metastatic colorectal cancer. Sometimes we to enlarge the ablative margin on RAS or BRAF mutation status. So I think we learned a lot from Professor Rim's lecture. So thanks again. We look forward to meeting you in GuangZhou next time. Thank you.